Thank you very much, Enrico. I'm going to speak about intracoronary imaging before we change gears for a reminder of this session to echocardiography. This is a slide of an histology section of an atherosclerotic plaque, and we do have many imaging modalities to visualize that. We can do that with coronary angiography, what we usually do. We can do that with intravascular ultrasound and ultrasound-derived techniques to look a little bit at the plaque, as Dr. Steiner already referred to in his presentation. We can use light, which is optical coherence tomography. I will show you some more details later on. We can also do some non-invasive imaging by MSCT and with MSCT-derived techniques. And you could also do something with MRI, but that is still in its infancy because that is still impossible to perform in moving coronary arteries. First, I wanted to give you a little bit more details and more insight about how difficult it actually is to visualize the atherosclerotic plaque. What we once did in a controlled environment was to take 15 consecutive slices, histology slices, in a row with 100 micron distances. And if you look to that and you take the first frame and you take the last frame of this section, which is only 1.5 millimeter long, you can see that there's a lot of difference between the first and the last frame, and I will show you that in a video in the next slide. These slides are stained with trichromason staining, and everything what is green is fibrotic tissue, everything what is whitish, that is necrotic and calcified tissue, everything here in the P, that is the intima and the plaque, purple, that are smooth muscle cells that are surrounding the vessel, and then the outer layer of the vessel is the adventitia, which is also from fibrotic tissue. Now if you watch this video, you can see that we have remodeling, you can see the vessel is growing here. Even the plaque will rotate in a second. You see the lumen will also change in this 1.5 millimeter only. And here you see some necrotic parts coming in. And also some calcification will come in. Now if we evaluate treatment and the patients are coming back 6 months or 2 years later, we want to visualize the exact same spots. And you see that only a slice mismatch can result in different conclusions which we draw. So we have to be very accurate to image these kind of patients. Now I want to draw your attention at the angio images here in A and here in B. If you look at that, you see some irregularities, but not actually very much. And we visualize actually only the lumen. If we now use intravascular imaging techniques like intravascular ultrasound with sound, you can see that here, which is proximal of an implanted stent, these test lines are identifying an implanted stent, that we have a large acoustic shadowed area which identifies that there is a lot of calcium. Distal of the stent, which looks fine on the angiography, you see that there is still a large plaque burden. Actually, on all these 3 cross sections, you can see that the lumen is everywhere approximately the same. These days, we also use optical coherence tomography, which is near infrared light, to visualize the coronary artery from the inside. It has a much higher resolution than intravascular ultrasound, and you can use it nicely to visualize stent struts. I wanted to freeze it for a moment, but you can use it to see if the stent struts are covered by tissue if the patient comes back, or if the stent is really good opposed to the vessel wall. However, the penetration depth is much lower as that of IVUS. With IVUS we can visualize the whole plaque, but with optical coherence tomography we can only visualize the first 2 millimeters. And if you look to an implanted stent, you can see here an histology section of a bioabsorbable stent. And this patient has come back after 6 months, and you can see that 6 months later that it is nicely covered. And at 2 years the stent is almost disappeared, and you can see that the optical coherence tomography images almost have the same resolution as histology sections. Now what are the advantages using these additional intracoronary imaging modalities on top of standard angiography? And I want to show you that at the hand of a clinical research example, which is a biodegradable stent, and the long-term follow-up using this multi-modality imaging approach. Bioabsorbable stents are considered to be the 4th revolution in intravascular treatment. First we had the balloon angioplasty, after that we had the stents, then the drug-eluting stents, and now maybe the bioabsorbable stents could be the fourth revolution. The bioabsorbable stents, they could theoretically overcome problems related to permanent metallic implanted stents, because they prohibit remodeling, no vessel motion, no dual antiplatelet therapy, and there's no fractures. If you want to read more about the background of this study, the Absorb study, you can read that in this paper published by Suarez in the Lancet 3 years ago. This is an image of such a bioabsorbable stent. It is made of a backbone of a semi-crystalline polymer polylactic acid, or maybe popular said, it's made of plastic. There are two tiny titanium markers, proximal and distal of the stent, to help you to guide the placement of the stent during X-ray, because you cannot see the plastic on X-ray. It is expected that this stent is going to disappear between 2 and 3 years. Now this is an artist impression. So the first thing what you do is the balloon angioplasty and the revascularization of the vessel and the implantation of the stent. Then we have a period of restoration, and then we have a period of desorption. The support of the stent is approximately between 3 and 6 months. Then the stent will lose its mass, and it will lose also the mechanical support. In the first month, the drug will be eluted. However, how this exactly works in each and every individual patient, we don't know, but we're very much interested to know that. Here you see an angiogram of a patient who has received such a PLLA stent. If I freeze it, and if I go to the next, you can see there are two tiny markers, which are the titanium markers, and to help you to place the stent. What we have done is the multi-modality imaging modalities. We have the IVUS-derived techniques such as echosonicity, what we developed in-house, and we have IVUS virtual histology. There is pulpography, and also the OCT. And if you look to the OCT, you can see that this is post-implantation. Post-implantation, we have some boxes of the stent that are the struts. You can look through the struts because they are made of plastic. 6 months later, we were horrified, because if you see this kind of pictures of the vessel wall, you think that will never become alright. But 2 years later, you can see that nature helped, and the vessels are almost back to the state in which the patient was just leaving the cath lab after stenting. Here you see the 3 modalities on top of each other. This is IVUS at the top, then we have OCT, and at the bottom we have MSCT. These two images are made at 2 years, and the MSCT has been performed at 18 months. What you can appreciate is that we would like to use IVUS to see the whole plaque. We want to have OCT to see if the struts are covered. And MSCT, that is a parallel investigation, because if you do long-term follow-up studies, the patients will probably in the future be more enthusiastic to have an MSCT than instead to go back to a cath lab. By the way, you can see here on the bottom that with MSCT, which is also with radiation, that the plastic stent, which is the PLLA stent, which is implanted here, is invisible. But a metallic stent, which has to be implanted as a bailout at the distal part of the absorb stent, is very much visible. It causes actually an artifact on MSCT. What do and can we measure for evaluation in the so-called vascular restoration therapy? As with any new drug-eluting stent, we want to measure the stent dimensions and the changes over time. We want to measure in-stent growth, try to identify strut coverage, and in addition, we want to measure plaque component changes. Follow the absorption process of the stent. Is a non-invasive follow-up possible? And we want to quantify vascular functions. Now, if we want to look if the stent is absorbed by MSCT, that is very difficult, because you can look to Hounsfield unit distribution, but the stent has a resolution which you cannot identify on MSCT. That is too rough. If you want to use OCT, which has the great resolution almost compatible to that of histology, you can see the boxes of the stent implanted. You can even measure it. It's only 150 micron. But at follow-up, you can see that the boxes are transferred into white dots. And how to quantify that in numbers? We always like numbers to quantify it. Actually, we cannot do that with OCT. We can only perform a qualitative absorption, which has been proposed. You have dissolved black box, dissolved bright box, preserved box and open boxes. However, if you look with intravascular ultrasound, you can see that post-implantation there are bright spots which identify the stent struts. And 6 months later, those bright spots are less bright, less echogenic. And that is something we can measure. Intravascular ultrasound shows different tissue components in a plaque due to the differences of the acoustic impedance. And what we can see is the three-layered appearance of the vessel wall. And at the outside, the adventitia. The adventitia, we know that is fibrotic tissue that is much brighter than the other tissues what we see. The media, which is mostly made of smooth muscle cells, is less echogenic. And the plaque that differs a little bit, soft plaques are hypoechogenic and plaques with calcium will be hyperechogenic. And we can make use of that. So first what we do is to identify in IVUS, in a pullback of such a stent, the lumen and the adventitia and the outer part of the vessel, and then we assume an adventitia layer around it. We not investigated one image, but we do that for all the frames, and then we can make a plot of the gray values of the adventitia. And then we take the mean of it. Everything what has a lower gray value we call hypo, everything what has a higher gray value we call hyperechogenic, or maybe better said, shown, if we assume this gray value is adventitia, everything what is brighter is hyper, everything what is less bright is hypo. This is by example calc in the plaque. And we exclude everything what is behind calcification, because with IVUS we cannot look behind calcification. Now if we transfer that image what I just showed you to a real example, and we color code that, and we make hyperechogenic tissue green, you can see that the outer part of the vessel is more hyperechogenic, which identifies then the adventitia. So this is an example. We have the white ring surrounding the vessel, which is the adventitia. Everything lower is hypo, everything higher is hyper. We can make a color code and we can calculate the relative fraction of hypo and hyperechogenic tissue. Now we go back to the BVF stent. You can see at baseline the stent struts and the diminished appearance at follow-up. If we put that into numbers, you can see that with pre-implantation and post-implantation, the hyperechogenic numbers of the stented area are going up. The patients coming 6 months later, they have a diminished appearance of echogenicity, and you see that goes on until 2 years. And if we calculate the mean of it, we get a curve like this. You see that after 2 years, we are almost back to pre-implantation values, identifying that the stent has almost been absorbed. So now coming back to the artist impression what we have in the beginning. How long does the support take, and is the support and the degradation of the stent, has that any relation to the type of patient in which we put the stent, or also with the type of plaque in which we have implanted the stent. So we investigated the late stent recall in relation to the plaque composition. And what we did, we identified fibrocellular plaques, fibronecrotic plaques, and calcific plaques. And if you look to the stent recall, what we have determined, and these numbers, the higher numbers are more recall, the lower numbers are less recall, then you can identify that patients with fibrocellular and fibronecrotic plaque in vessels which have still some life in it, and calcific, that there is a significant difference. In calcific plaques it seems that there is less recall, but that's probably because the vessels are much more stiffer. This has led to a redevelopment of this BVS design. Now we have the second generation of the BVS, and this stent is redesigned to reduce this kind of binary restenosis. It has a new backbone with a more uniform strut distribution, allowing more effective support of the arterial wall. This was the first generation, and this is now the second generation, which is currently into study. So in summary, intracoronary imaging of the atherosclerotic plaque can reveal details of coronary artery disease and help to evaluate new therapeutic treatments which currently cannot be detected by angiography alone. Thank you very much.
Thank you very much, Nico, for this multimodality presentation. The paper is open for discussion. If you have any comment, or questions related to the paper?
No.
I just have a simple question. When you define the different kind of plaques for this separation, this last slide that you showed, is there any criteria that was discrimination based on, or was just done by visual inspection, or this could affect eventually the results of the inter-observer assessment of these plaques or not?
Yeah, that's very well identified. Indeed, it is a qualitative assessment only. The last couple of years there has been a lot of, let's say, the last decade, there was a lot of interest to try to detect the vulnerable plaque, or the so-called vulnerable plaque, with all kinds of imaging modalities. But until now, nothing has been single, exclusive, that you can say this is the plaque composition. We only have that indirect, and better we use IVUS. That is too rough, and we cannot identify the different cells. With OCT we have a high resolution, but the penetration depth is not large enough. So actually we don't have anything else than what we can do qualitatively. And indeed, as you identify, then you have observer-related bias. That's why we always do this kind of studies by multiple observers.
Thank you. Did you investigate any correlation between the fractional flow reserve on the plaque morphology?
Well, there are studies about it, and I think they are in place as well, not by ourselves. But I must actually admit, last week we had a symposium about the absorbable stent in Rotterdam, in which there were live cases, also using FFR, OCT, IVUS, angiography, etc. And there are some kind of cutoff points where you take the FFR or the sizing of the vessel, etc. And honestly, the more technology we use, the more confused we are. Because the relationship between all those technologies is very difficult, and it is still a lot of work there to do.
On classification of the CT scan?
Yep. Classification.
They are correlated to the plaque geometry?
Yeah, but not all kinds of plaques are are already included. We had now 2 studies, the first in men, and we had the cohort B, which I showed you. Now there is the absorbed extend study. So it is not only, let's say, simple de novo lesions which are being stented now, but the population is being broader. But for instance, diabetic patients are not into the study yet. And so you start first with the simple ones and then try to expand to the more complicated lesions. But yeah, your point is well taken.
And there is a recent paper on the coronary spasm. They also investigate.
We are looking to the vascular restoration functions by acetylcholine. At follow-up, 2 to 3 years. Yeah, and then we look to if the vessel is indeed restored or not.
And you can identify patients at risk of spasm?
Well, not at risk of spasm, but we look if the vascular functions are restored. Spasm, that is not something what we see often.